Welcome, Dr. Heba.
Thank you. I don't know where the presentation is. Good afternoon, dear professors and colleagues. Thank you so much. I'm so honored to participate in Alexandria University Radiodiagnosis Department scientific meeting, a scientific conference, and my talk is Peritoneal Metastasis, PET-CT, the Keen Observer. As we all know, peritoneum is a large serosal membrane that's divided into two layers, the visceral and parietal peritoneum. In males, it forms a closed sac, while in females, it's perforated by the lateral ends of the fallopian tubes. The peritoneum is a favorable site for neoplastic lesions from primary and secondary malignancies, with the latter representing the majority. Detecting these deposits is crucial in the diagnosis and staging of the primary tumor to set the adequate treatment plan. As we all know, the routes of spread are through direct invasion from nearby organs, intraperitoneal, seeding, lymphatic, and hematogenous spread. PET-CT represents a new tool for the assessment of the peritoneal deposits, and though it lacks the morphological details, yet it has the ability to reveal the deposits through their FDG avidity, which makes the lesion appear obvious between the surroundings. As we can see here in this MAC image, the peritoneal deposit is obvious and clear with its avidity and FDG uptake. Peritoneal deposits appearance varies from minimal nodular thickening to large omental cake. As in this case, we can see the peritoneal deposit appear as an ill-defined soft tissue lesion seen along the hepatic border, while it can be large omental cake, as in this lymphoma patient, which has large omental and soft tissue deposits within the peritoneum and the oment. Peritoneal deposits might also be very small and not clearly visualized or hidden between the viscera and missed in the conventional CT images. As we can see here in this case, it appears no gross lesions, but if we look at the fused images, you can see the peritoneal deposits here in challenging sites between the bowel loops and posterior to the anterior abdominal wall. Combining both PET and CT scans together allow the proper assessment of the anatomical details, actual site and size of the deposit, its metabolic activity, whether high or low, as well as its behavior and response in the follow-up. We can see here in this case, we can see there's a peritoneal deposit at the left lumbar region. When we checked the MAC images, you can see that there is another area of high FDG avidity seen at the right lumbar region. At the fused images, you can see that both are peritoneal deposits, the left lumbar one and the one seen just next, related to the lower border of the liver. Also in PET-CT, we can use the dual point scan, the early and the late phases, which can discriminate between the deposit and the normal bowel activity in those deposits in challenging site in close proximity to the bowel loops. As in this case, you can see there is query peritoneal deposit here just next to the bowel loops. We asked for a delayed scan, and here you can see there is a tracer fixation at the same site, and also it shows higher FDG avidity in the delayed scan, favoring its neoplastic nature. FDG primary tumors will have FDG deposits. It's called the metabolic signature. So detecting the peritoneal deposits is not always that simple. Whereas PET-CT has all the above mentioned advantages, it depends on the FDG avidity of the lesion. And those which are non-FDG avid or insignificantly avid remain a challenge when too small or in tricky sites. Now we'll proceed to illustrate some of the cases done at our isotope and PET-CT unit at Ain Shams University. We start with case number 1. This is a 40-year-old male patient, known case of cancer colon, underwent surgical resection and referred for metastatic workup before therapy. We check first the conventional CT images at the operative bed, and here we can see that there is minimal thickening at the operative bed, which can be due to post-therapy or post-operative changes. And in the liver, we can see there is a hypodense focal lesion. We proceed to the fused images. The hepatic focal lesion is definitely a metastatic one, but when we look at the operative bed, there is a very small FDG avid nodule seen at the operative bed. It was query for us, is it residual tumoral tissue or what? So we asked for the delayed scan done 45 minutes after the initial one, and here what we get, we can see there is tracer fixation at the same exact site, and it revealed increase in the metabolic activity, increase in the uptake. So this case was reported as residual tumoral tissue at the operative bed. We proceed to case number 2, a 25-year-old male patient, known case of cancer colon as well, underwent surgical resection and referred for metastatic workup. And here we can see there is a soft tissue lesion query next to the bowel loops. We asked for the delayed scan, and there is tracer fixation at the same exact point with increase in the FDG avidity, and it was reported as a peritoneal deposit. This patient received chemotherapy and was referred for follow-up after 3 months after, and here you can see the dramatic response of the peritoneal deposit, now small in size, 1 centimeter, and show low-grade FDG avidity compared to the pre-therapy uptake. So this case was reported as excellent metabolic response to therapy. In case number 3, a 50-year-old female patient, known case of ovarian tumor, underwent total abdominal hysterectomy and bilateral salpingio-oophorectomy. She received chemotherapy and was referred for assessment. In the conventional CT images, no gross abnormalities seen, but if we proceed to the fused images, you can see there are multiple scattered small peritoneal deposits seen here in this image lateral to the gastric wall, and here along the serosal surface of the transverse colon just behind the anterior abdominal wall. These are challenging sites, can be missed in the conventional imaging. Another one here hiding between the small bowel loops. So this case was reported with peritoneal deposits. Here another one behind the posterior abdominal wall on the right lateral aspect. In case number 4, a 15-year-old child, known case of lymphoma and referred for follow-up. If we look here, the liver appears with multiple hypodense non-enhancing hepatic focal lesions, but the rest of the abdomen and pelvis appear fine with no gross soft tissue lesions. But when we checked the fused images, hepatic focal lesions are metabolically active, of course, but here there are also multiple ill-defined peritoneal deposits within the bowel loops, as you can see, and in the at the pelvis there are multiple deposits along the serosal surfaces of the bowel loops, as well as one here along the anterior wall of the rectum. In case number 5, a middle-aged female discovered during routine ultrasound bilateral ovarian simple and complicated cyst was referred to a gynecologist who suggested laparoscopic assessment and biopsy of the ovarian lesions. Then she was diagnosed with left ovarian clear cell carcinoma and referred for metastatic workup before surgical intervention. In the conventional CT images, we can see there are bilateral ovarian cysts, and no other gross abnormalities, but in the fused images we can see the right ovarian cyst is a simple one, the left one is FDG avid, this is the clear cell carcinoma, but what the PET-CT added is the presence of multiple peritoneal deposits seen arranged in a linear pattern around the uterine body. These lesions were not clearly visualized in the conventional CT images. As we proceed, you can see here the linear arrangement of the peritoneal deposits around the uterine body. And the last case is a 43-year-old male patient, known case of a neuroendocrine tumor, underwent surgical resection and referred for metastatic workup after the operation. As you can see in the conventional CT images, we can see there is a suspicious looking lymph node here at the left epiphrenic region. As we proceed through the contrast enhanced CT images, we can see there are retropancreatic, also suspicious looking lymph nodes showing suspicious features by CT criteria. When we checked the fused images, we can see these lymph nodes and these deposits, they are non-FDG avid or insignificantly avid. And we checked also the contrast enhanced CT images again, and we can see there are multiple peritoneal deposits. You can see in this image there's a deposit posterior to the transverse colon, which is also insignificantly or non-FDG avid. As we proceed, another two deposits seen lateral to the greater curvature of the stomach, and the lymph nodes, the retropancreatic lymph nodes, are non-FDG avid. This is called the metabolic signature. The primary tumor was non-FDG avid, so its deposits will be non-FDG avid too. This case was reported as metastatic neuroendocrine tumor, and we suggested the further follow-up will be done with 68 gallium DOTA for proper assessment of these deposits and if any other hidden lesions not apparent in the FDG. My take-home message is the peritoneum represents a common site for primary and secondary deposits, the latter being more. Peritoneal deposits have various shapes in imaging, and their diagnosis with conventional CT only might represent a challenge if too small or in hidden places. PET-CT is an excellent tool for picking up the tricky lesions, assess their site size and their metabolic behavior. Non-FDG avid primary tumor and their metastatic lesions may be missed if we only depend on the PET images and the avidity of the lesions, and then we neglect to search carefully in the CT images, what's called the metabolic signature. You have to keep it in your mind. And last, PET-CT preoperative staging is mandatory. Thank you.
Thank you, Dr. Heba, for your nice presentation and your nice cases.
Now we are pleased to call for Dr. Mohsen Abdul Mohsen to tell us about the rectal opportunity.